Vasi, karibu sana
Thank you very much,
to
Asante
the
sana.
show. And
It's
you
always
hear,
good to be here.
yes. Now you've heard from the Israeli ambassador whom we're hosting, Oded Joseph, and what he was talking about. He's given us now, in terms of vaccines and how they rolled out their vaccines. First of all, even before the FDA had made its decision, they had already bought some of those vaccines and said, let them come to the country. Let's just wait for the go-ahead. Go-ahead is given rollout vaccination campaign, supported very well and very much by the organized healthcare system, which has been there for very many years in terms of what do they have, what do they have from the ground, from basic healthcare to the national healthcare system. He was telling us that even when he's here in Nairobi, he's already received SMS alerts telling him, you qualify among the people who should be receiving your vaccination at this point. Please take yourself to XXX health facility. And if you don't respond, they follow up and call you again. Now, you see that picture?
I have seen it.
Okay, what do you say?
You know, devolution, taken to its logical conclusion, it's like if you come from this area,
Yeah.
one, there are schools you can go to because they're within your area. Health services the same. And they know you and they have your details. There's no hit and miss here. They even know where you are. Your age, your children, your what. They have all that. So getting hold of you, not difficult.
You know, this is here in Kenya, I would say in a perfect world, that is what we would aspire to have. So them already, they're in a perfect world. And if you see at the evaluations that people are doing of countries that are doing vaccinations, Israel is actually at the top of the countries that are doing very well. The countries where people are saying, you know, we need to emulate this country for what they are doing in terms of rolling out their vaccinations and making sure that all the vulnerable people are reached and you make sure that everyone is vaccinated. So in our country, we have the grand plan, but those finer details is now what you do not have.
Actually, not even finer. The fundamental details and the details that guarantee that these things work don't exist.
What is fundamental?
Fundamental is this. A health service that you can rely on. You know very well what to expect when you go to a health facility. And if it is segmented and devolved as it is, even when you go there, they already know who you are. You mention your name,
It's up there.
your data is there. So they know. And so when you talk, they listen to you from an informed position. Not this hit and miss situation where you start from scratch every time you go to see a doctor. And the history that you have, unless your doctor comes in, then, or the doctor who attends to you often enough, then they don't really know what it is that they're handling and managing. So even managing health becomes easier. Much easier.
But does it take much to get there?
No.
At least to get to the basics of such.
No, it doesn't. No. It doesn't. If I look at the care and treatment programs that we had that were rolled out in this country for HIV, similar system. Similar.
Okay, so can we
know exactly who these people are.
So can we look at what that system looks like? Because we can say system, we can throw these words out there, and then people who are listening who may think, okay, what would it require for something like that to happen so that this thing can be rolled out smoothly? We get the information that we need. Folks go to one place or the other to get their vaccination. Because when we use these words, to people who may listen, it may sound like it's some huge database that now must be invented and created. There must be a drive going through the whole country. I mean, what would be necessary to have so you have the very basics that is needed to roll out something like this?
You know what CT is talking about, where, and this is the experience of almost everyone. When you go to hospital A, you have to start from scratch. My name is so-and-so, I come from this. This is the last time I was in hospital. Some you may not remember. People don't always even remember what was done in the hospital. When you go to hospital B, you start all over again. So the system or the situation we are talking about is one such that it does not matter whether I'm in Nairobi or I'm in Turkana. If I show up in the health facility and they key in, let's say, my identification number or my surname, any one of those, then all my data is there.
And history.
And that is information that should be shared across all the health facilities. So in the HIV system, for example, and some of these funded programs, they have the database of who is who, where they are, how old they are, their kind of household, all of this data, which would be important in a situation like now where you want to roll out an adult vaccine, because you want to know who are you over 80, for example, and where are they? Who are you over your 70? Who are the people who are living with pre-existing conditions, and where are they? Who else is within them, so that you decide, are you going to vaccinate according to family units because of the risks around it? Or are you going to just, vaccinate just age-based, healthcare workers-based, that kind of system? So that information exists in the country, but it is in silos. You find that most of our private hospitals are very good systems which speak to each other, but within the network of the private hospitals. The public hospitals is still your hard copy file, where you need to give a number, then somebody goes to the record, and then they peruse through the files.
Good grief.
You find the programs, HIV, TB, malaria, have their own set of system, the nutrition program. So all of this data is all over the place. So it needs something that will, bring all of this together, and all of it talk to each other.
So what is that thing?
Some years ago, some
Technology.
people spent nights, I'm sure, and days at the Ministry of Health. Some people who were just experts on this, and they came up with a plan. And they said, we can actually roll out this thing that connects all the hospitals countrywide. And they called it managed equipment. Well, I don't know whether that was the initial name, but it was a plan like that, which was then rolled out and called MES, where equipment was brought in. And among the components of that was that digitization and harmonization of data, which, of course, now we know what happened. But can you imagine if that had been rolled out, where every health facility in this country can actually be accessed from one central location, and you can get the information that if you're referring a patient from this health facility to another health facility, all that information is just pulled up.
Yeah, it would make life much easier. And what we've been saying is that COVID has, as Citi says, exposed the underbelly of our health system. It has exposed our weaknesses. And unfortunately, we don't seem to be learning and doing something, to change that course.
Yeah. The fact that such a plan was actually mooted, the fact that such a plan was discussed and it went above to senior managers, to the management of the Ministry of Health, to cabinet, it means it's possible.
It is, definitely.
It means it's also possible to fund such a program. It means that we could get it done.
And it also means it is not even as expensive as they'd like
It's
to make
not
it think like
it's not expensive.
It's not.
We already have, there are various other projects. There's the NOFB, the National Fiber Optic Project, that connects the entire country to a fiber optic cable. So internet and infrastructure-wise, it's possible to get it done. Those are the things that you're saying. We are exposed like this, and then we shift our focus to other issues of politics, and we forget to raise those questions. Why hasn't that been rolled out? What you're talking about now, we don't have a plan and a program on COVID. It hasn't been made public. Maybe there is one.
Yeah, that's more like it.
The information.
The ministry says there's a plan.
Yeah.
They have it all out.
Everything
but
is sorted.
we need to see it.
For instance, when you talk about, say, digitizing your record systems, one of the complaints that was put forward a long time ago was power, electricity is not available.
Yeah.
So even when electricity then became available and a backup service was provided in the form of a generator, you would still find complaints.
Yeah.
You would still find issues as to why this isn't happening and why it should. That one was standard.
It's always standard.
Standard. I mean, it's so standard. It's like ticks on a dog. You guaranteed. Now, there seems to be a mindset that anything that actually brings positive progress must be fought and removed. All these things we talk about. A biometric system, which again is not as expensive as people make it seem to be, would sort out many of these problems. All a patient needs to do is thumbprint. That's it. You already know who the person is.
Yep.
This story of sending someone half a kilometer away to go and look for the file.
Go and get your file and come with your file. And you're sick, by the way. You
Oh, no,
have
you're-
gone to hospital because you're
sick.
unwell. And then you're being told now, enda kwa ile ofisi chukua file.
And the file is not there. Then
Enda
what do you do?
pale
file
kwa
is not
cashier.
And sometimes you don't even remember the last thing that ailed you. Because some of those things can assist the doctors to make a diagnosis or to help you. Sometimes you don't remember. or people who, in hospitals, we have this many unknown African males, unknown African females. You know, somebody who's had an accident, for example, they can't remember who they are.
Yeah.
Nobody knows who they are.
This is
you
an
know.
unknown African male.
Imagine if you had just a thumbprint, you'd be able to pull out, see their next of kin and everything like that, and be able to connect them back with their families. But it's a fundamental problem with our health system that we know where the issues are, we know where the pain points are, but we are not doing anything about it. We just keep talking about this universal health coverage. We keep talking about, we want to improve healthcare, but it's just talk and talk and talk. But there's really nothing tangible that
You know what's actually tragic about it? What is truly tragic is that anytime you talk about these systems and these processes working, there was external assistance accorded in terms of funding. And there was an insistence by the provider that certain things must be done, like monitoring and evaluation were a must.
Yeah.
So order had to be kept. Now, why I'm saying it's tragic is that people who seem to be in authority and decision-making positions then more or less sit back and wait for that sort of assistance to come along before anything can be done. So they'll talk, and as far as they're concerned, they've done their bit. They've talked. You only need to look at the services that ran smoothly in this country because of PEPFAR funding, and when funding was reduced, not removed.
Yeah.
You will not believe the shambles that
Night
followed.
and day.
One of them is the blood program.
Yep.
The blood program. And up to now...
What's the
we're
update
still
on that, by the way? So, team formed, team taken to court, team removed, team brought back in. Who's running our national blood transfusion services?
The last time I checked, I think somebody from the ministry had been assigned that to oversee, because remember when COVID started, one of this first 6 billion funding on COVID, 1 billion was to go into the blood transfusion.
Yep.
So that's when all of this was there. I don't have any tangible update as yet. I just know there was a team that was already now starting to have meetings.
A team had been formed, then the CS decided, no, this team does not need to work, we'll run it straight from the ministry.
Yes. So the team from the ministry. So they've been having meetings and conversations.
Of course they have.
Yeah, but I still see people struggling to get blood.
What needs? I'm perplexed. What needs to happen? There seems to be so much, because you said something very interesting, is that we know what the problem is, right? And it's established that there's a problem, acceptance that there's a problem, but it seems that to move from where we've spoken and talked about the problem over and over again, and then to actually put things in place to get rid of this problem, there's something that's blocking that. What is that? And what needs to be done to remove it? Because then my next question would be, you have cases like this of COVID, and based on what we're talking about today, things would definitely get worse before they got better. If you're trying to sort out a problem and on an already ailing system, it's going to get worse.
Our main problem, usually, we talk about funding, that we don't have enough resources for this, we don't have enough funds. So we have all these grand ideas, but when it comes to implementation, we say we don't have funding. Then when we look at the budgetary allocations, it's truly not adequate. But then at the time when there's a global health crisis, who would you get that will give you donor funding for some of these programs that ideally, as a country, you should be able to be funding for yourself? For example, the blood program or the PEPFAR funded programs, where the country knew for 15 years that this funding will come to an end at some point. So they're supposed to have, increased the funding to be commensurate with what was happening so that you maintain the services. So when it comes to all of this, it's usually when you get to the point of funding, they're like, no, we don't have funds. We need to do resource mobilization. We need to get partners, funders, donors. And the conversation continues from there. As Citi says, the programs that are funded run very well because there are some certain strict things that people have to meet. You have to see through, you have to meet all of those requirements for you to continue enjoying those funds. So those programs tend to run well.
Does Kenya need external help to sort out this COVID-19 thing? No. Does Kenya need external help to, because if we're saying, look at it, if we are saying that something as basic as getting your file, your personal file, to come and get you treated when you are ill, that's you, one individual, and then you happens all across the country. Now we are talking about a national a problem that affects the nation in all corners. You want to make sure that you are inoculating or vaccinating your most vulnerable first, those on the front line. It needs information at the same time as it needs action. It is clear that that cannot be done, has not been done, is not being done. They have a problem getting it done. So do you need external help to have this sorted out? It may sound like something you don't want to admit to, but...
Before she responds, can I ask you a question? When you say external, how far do you want it to go? Do you want it to be divine, coming down?
No, divine.
Divine.
No, I think divine, we've already established that one is a necessity. But that one is a necessity. Divine help, absolutely. But look at the examples
You're
that
helped
you've
by
talked
another
about.
human being who is not Kenyan.
Right.
Thank you, Eric.
This
For
PEPFAR
the
funding that you talked
clarification.
about, look at the things that happened when, because PEPFAR will not just give you their money. They'll give you their money, and then they will go in to ensure that whatever you said you would do with this money is done. Whether they need people to be in there monitoring and supervising, the work is done. People's lives are affected. It's done better. Now, look at this COVID. I don't know if... look at it as it is. Do you think that that's what's going to be needed to sort that out?
I get your question, but my honest answer is that I don't know, because every country is trying to save their people. So who will come and help you to save your people?
Okay. Let me ask this other question. Now, as a medical doctor, there's always been this debate about what healthcare approach, public healthcare, should you have, the preventative versus the curative approach. And the argument, the preventative may be whatever the argument may be, all right? COVID has shown something very peculiar. Human beings are the same everywhere. Because the problems we keep talking about with reference to Kenyans, it's everywhere. Just take your pick. All the activities that Kenyans have done to sort of like disregard COVID and just do it's everywhere in the world. However, do you think that if we took a preventative approach to our public health care process, that many of these issues that we have would not exist? And now let me tell you why I am asking this question. When I was a child, I was actually a child once. When I was a child, growing up, one of the things that I witnessed, I even knew it because there were these people who were referred to extension officers. You even had health extension officers who came around to tell mothers. But they were in town as well as even rural areas. But rural areas, they're more pronounced because they would actually come to the home. And they were never in a hurry. Then there were agriculture. Those are the two I remember. But when I say health, there were these people who sprayed plants and trees with DDT, whatever it is that they spray to kill mosquitoes and what have you. Now, would that approach to healthcare be something that we could afford?
If you look at the gains that you would get in the long run from that approach, definitely it's a matter of looking at your return on investment, really. Because if you're going to invest in preventing disease, it means all the money that you would have used to cure these people when they fall sick, you've saved it. And then the other return on investment that you may not realize in the immediate part is that you have a healthy population. And a healthy population means that they are productive. And so your economy does well. So if you look at the West, where they have managed a lot of the communicable diseases over time, they have gotten somewhere. So as a country, what should happen, because we're still battling communicable diseases which can be prevented, we're still battling non-communicable diseases, cancer, for example, you still need both the curative aspect, is to try and, invest in both arms of healthcare, from preventive and promotive. And over time, you increase on what you're spending on your preventive and promotive, because then your curative side will go down. So it's just a matter of prioritizing and seeing what really is ailing our people. Is it diarrhea? Is it pneumonia? And we've seen that. So we expect, for example, the numbers of diarrheal diseases, upper respiratory diseases to have reduced in 2020 because people are washing their hands, people are distancing, those reduced activity. And what that will tell you is that, if you put a lot on prevention of disease, then you do not have to burden your hospitals with things that could have otherwise been managed at home. So for me, it's where we are as a country is investing in both.
It's just investing.
But with time, you are heavy on the prevention.
Let me throw in just a little mud into the situation. Let me muddy the waters a little bit. According to a national household survey released by the Kenya National Bureau of Statistics, this is February 8th, 2019, 57% population of our country seek treatment from traditional healers and herbalists, compared to 26% who access health facilities.
67%.
No, 50.
57%. More than half of the country go to traditional healers and herbalists.
Yes.
Every 3 in 5 people.
Only 28% seek.
So if you take the statistics here, 3 of you have seen a herbalist.
Would go to a herbalist at any one time if we fell sick.
But that says something, because and from my own experience, people don't go to hospital just to be treated for that thing that has taken you. You may have a headache, you may have broken your leg, but sometimes you want somebody to talk to. You want somebody that will seem like they are doing an instant healing, some miracle. There's something else that you want, and probably the herbalist traditional healers provide, they'll tell you, if you take this, all your problems are gone for good.
No, then they take care of all your needs, actually, and they're not in a hurry. They're not looking at their clock, and usually there's somebody you know. So they are not just people who look after your immediate physical health care needs. They also look after your psychological needs and even your spiritual needs.
Now, actually, that we talk about somebody I'm thinking of maybe digging deeper into that survey and finding out how do they describe these traditional healers and herbalists. Maybe it's also when you talk to a neighbor and the neighbor tells you, I used this and the other. It's also categorized in that. As in one of the reasons why somebody fell ill and they sought assistance outside of a health facility, a recognized health facility, then maybe they are lumped into that traditional healers, herbalists, friends, colleagues, elder brothers, the elders in the community, all those are categorized as one. We talk about that issue, though, of public health vis-a-vis looking at how to look at the medical side of things. Again, I'm sure you have interacted with people at the Ministry of Health. A lot of attention is put on paper on this, on preventive healthcare, on public health. A lot of experts are there, and they say, our attention should be here. At some point, was it during the Grand Coalition government, the Ministry of Health was split into two, one to focus entirely on preventive public health, and the other one now on the other side. Okay, we brought them back. But at the national level, we have a director of public health. That tells you that somewhere in Afia House, there are people who work and they think and they design programs. It moves out of there, it goes into a political office. And the political office and the commercial side of things maybe just messes up our thinking.
Public health currently is under the counties. I remember all of these things, whether from the Ministry of Health, from the county governments, all of these things need money. What city is talking about? Your community health workers, your agricultural extension officers, those people need money. I've been to West Pokot, I've been to Uasin Gishu, all of those areas. And sometimes they don't have what you're talking about here, and we may laugh, but it's very serious. They don't have fuel for their bodas because that's the means of transport to access people. So when there's an outbreak, for example, and this time I was covering cholera, when there's an outbreak, they can't access some of those areas because there's no car that can go there, and your your motorbike does not have fuel. So how are you going to reach your people? And this is not just when there's an outbreak, but it's your almost daily thing. So people go to the office, but there's nothing much to do because you haven't been facilitated to do some of these things. If you want to go and, do the spraying or, sensitize people about cutting their grass, all of these things need funding. So if you don't put money where your mouth is, you cannot expect different results.
All right, your mercy, because even before devolution, when you had district hospitals, you would find, for instance, the two individuals who are supposed to be the community officers in that particular, and I'm talking about social welfare officers, have not visited that large district in a year. And the reason is the very thing you're saying. Many a time you will actually be approached by the med soup. Simple problem, fuel for their vehicles. Because they would like to go, they would like to visit, no fuel. I remember in the county of Homa Bay, there was a small matter of visiting the islands of Remba and Ringiti. Now, the healthcare service didn't exist there, so let's just start there. Not only that, but even at a certain point in time, even a police service did not exist. So, for them to actually visit this, they would need you to provide them with a boat, which at that point that we had. Essentially, you have to take them to visit an area that they should be covering. So, yes, resources in many, many ways were not available. So you used to wonder, so if somebody falls sick here, what on earth do you do?
So what happens? Herbalist, traditional healer.
Precisely, because there'll be somebody.
It's accessible.
Yes.
Spice FM, KTN Home, and Spice FM KE on YouTube, on Facebook, and Twitter. We have in the studio with us Dr. Mercy Korir, Group Lead Editor in charge of Health and Science at the Standard Group. And we're talking about COVID-19 and the spread. In the next hour, we'll be talking about vaccination and the drive for vaccination globally and especially in the country. For now, it's about the spread of COVID-19 and the management of COVID-19. Before we talk about the Kemri report, if you just look back at COVID from last year, COVID up to this year in this country, Ministry of Health programs, what the Ministry of Health has done in terms of information, in terms of coordination at national and county level, how would we rate the ministry? Would we say that we're where we are because the government has done very much what it could and has even allocated extra resources into this, or could we say that the government has just floated on the waters?
Kwa Kiswahili wanasema mgala muwe na haki
Haki
mpe.
yake mpe.
So we'll give credit to the ministry for the kind of thing that they've done, and I think for me the one thing that stood out was taking charge of leadership of the pandemic. That in itself, when the emergency response committee was set up, that whole committee, it signaled that we are taking this seriously, and there is a channel in which this coordination mechanism, in which the fight against COVID would be done. And that's important because when you have many centers of power, then you will tend to have many people doing their own things.
Yeah.
So for me, that was the one thing that I think the government, the Ministry of Health got right, because then you are able to coordinate both at the national and the county level. Initially, when we had the call center, for example, where people could call in to find information, the regular updates.
We no longer have that?
Well,
is it functioning?
Yeah, that's the question.
Was it there?
Yes.
Initially?
Yes.
Yes.
And it was 24-hour manned, and you could get
Yes.
through and you could call and ask.
Yes, because
Right.
it was manned by doctors, doctors and medics. Really, there was a whole good system, and even up to a referral system where if you need an ambulance, if you need to be evacuated, that was there. And at least I saw that they were actually responding. And it was interesting because at the time, even people called for things that are not even COVID related. I remember one of the times when I was there's a lady who called because she didn't have food for her children. And so she was referred to where she could get food under the Red Cross. So it was really working, not just addressing COVID issues, but other, concerns that people had. So for me, that was a big plus. The regular updates, by the ministry that this is what is happening, these are the numbers. Just ignore the kind of information that was there because
ignore the detail.
We had a lot of issues, and anyway, that is the work of the fourth estate to ask questions. But that in itself was a plus because all of us who are on the same boat as a country, in that we know this is where we are, these are the numbers, this is where we want to go, this is what we think we should do, and that helps for you to rally people around you. Now the details is where we had all the issues. When it came to, for me personally, issues of charging for isolation, for example, issues of charging for testing, because that's where you get it wrong. Because if I don't have money and I have COVID, I will stay at home, or I will continue, looking for my bread and butter, and I will spread the disease. And so that is the part where I think we started getting it wrong, by charging people for testing, for isolation and treatment, by not initiating home-based quarantine from the very start, because we had seen from other countries that this disease people could quarantine at home, but then we had people being quarantined in hotels and in institutions where they had to pay. And in these institutions, there was really nothing much that they were doing. So I think that is where we started getting it wrong. The other part is where we were not safeguarding our healthcare workers by providing them with proper personal protective equipment, where people are using one mask for the whole week, or you're only given 2 masks for the whole week. So you have to rewind. You have to find innovative ways of recycling your mask, where some people, gloves were expensive at some point. Hospitals could not afford gloves. And this is our public institution. So some of these things, we got them wrong at that point, and that could have contributed to the numbers as we saw them. Luckily, and this has been the story in the whole of Africa, it hasn't been as bad as we thought it would have been, despite all the shortcomings that we
had been told to anticipate it might be.
Yeah. So, I think God cannot punish you twice.
Explain, please.
You have a disease, you have a bad health system and everything. He cannot come and then make it decimate.
You know what I've just heard you say?
What?
The first punishment is being born in Africa.
Oh, no. No. The first punishment is that you have a bad health system and then a disease has come. He cannot now make it worse.
Let me ask the question. I'm moving away from what we've been talking about. When we talked about it, we'll probably talk about it later, when we talked about the strike of the healthcare workers, the thing that struck with me was the lack or the unavailability of protective gear. Has that in any way changed?
I think it has. And at
I
least
mean, for the better, not
Yes.
it could change for the worse. I mean, for the better. Yes.
No, it has definitely improved. And the improvements here is because we started seeing local manufacturing. That actually played a big part in seeing the changes that we saw. And then also, over time, we learned a lot about the virus that you could actually do with proper gloves, a proper mask, and if you have a visor or your goggles and you have your boots, you can be okay. You don't have the spacesuit or the hazmat. And so we've seen with that there's been an improvement, so that these full hazmat suits, you just leave them for the people who are in direct isolation centers, and these other people who are meeting these patients in these other areas, you make sure they have a certain degree of protection. And then over time, also hospitals planned their patient flow so that those who are coming to COVID are not in contact with these other people, so that you're able to balance how you're going to use your personal protective equipment. So it has improved, definitely, with us learning the nature of the virus. And then if it's any consolation to the country, we are not the only ones struggling with personal protective equipment. We saw the US, for example, and now with the change of administration, they are talking about, ramping up the production of some of these personal protective equipment, which also the frontline healthcare workers were running short of at some point, that they didn't have gloves, they didn't have masks, something unheard of for a first world country. So it wasn't really unique for us, but when we saw local solutions coming up, then there was some improvement along the way. But we can do better, definitely, but we're not as bad as we were, at the very beginning. And I don't know why. Maybe people were hoarding. the personal protective equipment. I don't know. Maybe people were.
But didn't we read that a good portion of the protective equipment that had come into Kenya were when some go down somewhere waiting some approval from someone so that they could actually be released.
There was an investigation which was rolling
Taking
the
place forever. And, so, I mean, when it comes to discussing protective equipment, the stories around it, they're mind-boggling.
We can write a book about it.
Yes, you can. You can even make a movie.
Because the probe is still ongoing. Yesterday, KEMSA was in Parliament. Was it KEMSA? There was a conversation on that. So
that we expect. They will go to
still ongoing.
Parliament. They may even go, Parliament as in National Assembly, they may even go to the Senate.
They've already done that.
Remember, even the Senate did something better. They even wrote a report.
That was the MES. The Senate
was the
report
MES
on
handle,
on KEMSA is still.
it's still work in
Well,
Still
progress.
waiting.
Actually,
Okay.
There's a health committee report from the National Assembly on KEMSA. We expect many more reports.
That is why I mentioned the MES one, because people who are under investigation visit these two august houses. Yes, but if we're talking about a diviner, this one I can divine.
Really? What sayest thou?
I can actually say that they will go, they will meet, a report will be written.
And then they'll get to the next
Bas.
tender.
Yes.
Oh, you're done. Okay. So that's the situation. I mean, that's the situation that we're looking at now. And I mean, so here we are a week to maybe 2 weeks to when these vaccines, because let's come back to COVID, to when these vaccines are supposed to be making their way into the country. I mean, and I know that we had looked at a Wednesday before last week when this announcement was then supposed to be made, and then now the information was supposed to be spread out into the country in terms of what was supposed to be to have happened. Okay, well, even that report did not. At least it was not made public. So maybe the information has been left to the committee that's dealing with that right now. But so as people, as citizens, what should we do from your point of view when something is supposed to be coming into the country that is going to benefit them? So do people just wait twiddling their thumbs and wait for the information to come, and then when we're told it's this day, then we go? Or is there some kind of mental preparation that people should be going through? What would you advise? Knowing that you have an authority that should be giving this information, it's not. Okay? Like, for example, Israel, we spoke to this morning. People knew what they were supposed to be doing. When, where, when, how, what. They knew. That information was shared. Even in the United States, where things are a little bit, up and down, people have a general idea of what is supposed to be happening as far as these vaccines are concerned, right? What? Should people be prepared, or should people just wait?
It's a difficult question, because without knowing what we are waiting for, it's difficult to know. Because even personally, I'm not to be pessimistic, but the February target to me seems like a very ambitious plan, seeing what is happening globally. So I don't know, from that in itself, I don't know how possible that is. But maybe the Ministry of Health knows something we don't know. I don't know. But for me, the advice to Kenyans is, where we are now, just protect yourself from getting the disease. Wear your mask, wash your hands, distance, don't go to political rallies, or places that are crowded. Just protect yourself from getting... Do the best
you can.
Yes, not to get the disease.
But Ndu, when you say what should we be preparing for, what do you have in mind? In terms of what?
Well, I mean, look at it. What was it? Look at when we talked about quarantine and isolation. Is that if you had somebody in your home who was presenting with symptoms, or then who was found to be infected, you kind of knew what to do. Do you? And before they announced self-quarantine, you kind of knew, okay, I can speak to somebody, and I know that I need to take this person to this quarantine facility, right? So you had an idea. So right now, you know whether you are a health worker, you know whether you are a vulnerable person, whether you are predisposed because of your age, So should you be prepared? As okay, since we know that these are the first set of people that will get, so come February, I know that I need to go to this place or the other. So should it be there should be some kind of information right now saying, if you fall into 1, 2, 3, be be preparing yourself for the next couple of weeks to know that you should go and get your vaccine, and that in the next 3 months, 10 weeks, whatever, you should go and get the second one.
Okay, so when it came to isolation, quarantine, quarantine, for example, that's not something that needed government intervention as such, because this was from an individual perspective. Like, for example, if you're told you stay at home, don't interact with people, that is something you can do by yourself. But here, when you're talking about the vaccine, unfortunately, this is not something that you can procure for yourself. It's not, okay, maybe some people can, I don't know, but it's not something that your regular Kenyan can go and get for themselves. That's one. Two, it needs a certain supply chain mechanism, because if you need to store it in a fridge, as in there's a process in which it needs to come in. There's a process in which it needs to be distributed. So that in itself is information that should be there. But now this is for the people who will be actively, distributing the vaccine. The other thing is we don't know whether it, for example, you'll start from Nairobi, Mombasa, and then if you're starting from Nairobi, what will be your centers? Is it a drive-through? Somewhere? Is it come and queue at Kenyatta? These are some of the information that you need. And then from there, once you know where is when, maybe come in the morning, or it will be throughout the day, or after you get your first dose, you need to come back after 3 weeks, 4 weeks at this particular facility, or we'll come to your home now that we have your details. These are all information that we don't have to tell people now. You need to prepare. If we had this information, then we'd say anyone over 70, the government is saying, at this and this date, go and queue at this particular place, or you wait, we'll come to where you are. We don't have that information. It's difficult to say prepare.
But Mercy, even if we were to roll it out, do we even have the personnel to do this? Because remember, even as you're vaccinating, normal healthcare services are to go on. So my question, do we have the personnel?
These are all the balls that are in the air that are making the government not be able to communicate at this point. Number one, the government maybe is not 100% sure when it's going to be able to secure the COVID vaccines and to get them in the country. So now it starts telling the people, be ready for when?
Eric,
for March, for April, for February, for March.
Add to this conversation by asking this question. Why is the government not sure? The government is very sure about how they want to tax us. They are very sure about how much they collect. They're very sure.
Yeah, they're in charge of that infrastructure.
Now,
you are there and they know how they'll get
They know exactly how they're going to get me. Now, you are telling me that a government that is that diligent in collecting taxes is not diligent in trying to tell us how it is. We know the vaccine has to be procured. We know this. The government collects money. So it's not that it doesn't have money. It has money. Because they collect taxes daily. Are you telling me that they're not capable of prioritizing and saying, folks, with this money that we're collecting, this is what we're going to do?
I think they and I'm not holding brief for government here. I'm just thinking all those priorities and everything is in place. But look at the lessons learned and taken during the address of COVID-19 in the last 1 year. International supply chain. Are we able to tell when we are going to receive the next testing kits? Are we able to tell when we are going to receive the next reagents? Are we able to? So yes, we are making all the efforts, but then things are happening.
Do we actually know where they're making all the efforts? I mean, look.
No, this is what I'm saying. I'm just saying. I'm thinking. Plans, according to what the CS for Health has said, our plan is to try and procure these vaccines or the vaccines are in the country by February. Mid-February, okay? Or thereabouts. That is their plan. And then now you go to the reality. Vituko ground. Okay, ground. Where is it? We're getting ours from Oxford. Okay, how are we going to be able to procure and secure these ones that are coming in? These are part of the global vaccine initiative. Everybody else is receiving them at the same time. Are we going to be receiving ours within the timelines that we stipulated? Are we in control of that? If the government is not in control of all these things, then now it's
Eric, I'm saying they're in control. You know, I'm saying they're in control. We are not inventing vaccinations, or neither are we inventing the process of vaccinating. The Ministry of Health has programs. And they're timed. You know, this is what they're going to do with TB. This is what they have it. And believe me, it is rolled out. It is conducted, it is done. It's not that we don't know. And it isn't that we haven't done these things before. We have.
That's true.
And, you know, and the beauty of the COVID vaccine is that we are seeing what is happening in the US, in the UK, in Israel. We are seeing.
This is the Situation Room, the only way to start your day.